Okay, good afternoon, everyone. Welcome to Medicine Grand Rounds. Thank you for joining us today in person, and for those of you virtually, welcome as well. A couple of updates. Next week, October 23rd, we're welcoming back one of our own, Dr. Silk Soto, Associate Vice Chancellor at Pittsburgh University. And October 30th, we are pleased to host FDA Commissioner Dr. Rob Califf, who will be here talking a lot about the policy changes and interventions they're implementing at FDA. Reminder, please continue to attend in person. It's great to meet people here in the room. You get to grab lunch, and of course, we get to learn together. A plug for Mentorship Academy in 2024. We're about 2.5 to 3 weeks away. It's on Monday, November 4th. It's an all-day event at the Hyatt. We are sold out, and what that means is we have 400 people registered to come, the majority of which are coming from our campus, and I'm really pleased to say more than half of those people attending are faculty who are women. And I think this is a great sort of testament to the need for this, but also the fact that we are able to attract this group for the day. So look forward to seeing many of you there. And now it is my pleasure to introduce Dr. Sarah Young. Dr. Young is an associate professor of clinical practice in the Division of Renal Disease and Hypertension. She was born in Oregon and raised in Europe and Latin America. She earned her BA from Columbia University and her MD from the University of Chicago Pritzker School of Medicine. She remained in Chicago for her IM residency, served as a chief resident, and completed a fellowship in critical care medicine. Dr. Young moved to Denver in 2001, where she completed her nephrology fellowship here in the University of Colorado. She is boarded in internal medicine, critical care, and nephrology, and then decided to enter private practice, because that's what you do when you're triple boarded, and spent 13 years treating patients with kidney disease and serving as medical director for several dialysis facilities in Denver. We were fortunate to recruit her to CU in 2019. Here, she serves as the nephrology provider for the Rheumatology Renal Clinic, which is a multidisciplinary clinic that cares for patients with autoimmune disease and kidney disease. And alongside her special expertise in lupus nephritis, she has a passion for the relationship between climate change and kidney disease, and has published and spoken about this topic nationally as well. Please join me in welcoming Dr. Young to the podium for Grand Rounds, entitled, "What Do the Kidneys Have to Do with the Climate? The Intersection of Climate Change, Kidney Disease, and Clinical Care." Welcome, Dr. Young.
So the real challenge is getting my PowerPoint up here, so let's see. So first of all, thank you for having me at Grand Rounds. Can you hear me? Thank you for having me at Grand Rounds. Can you hear me? Okay. So I'm going to be talking about climate and kidney disease, so you can anticipate a really optimistic, very fun-filled discussion for the next 45 minutes. I'm going to try to keep it light, because one of the challenges about talking about climate is that people get sad and then they want to turn it off. So none of you are allowed to tune me out for the next 45 minutes. And sorry, I'm getting my laser pointer. So I have no official disclosures, although I should probably disclose to the audience that I believe in climate change, which I'm assuming most of you figured out based on the title of the talk. I have 3 objectives for today. One is to understand climate change as a public health threat, to review the impact of climate change on patients with kidney disease, and then to recognize the role of the healthcare industry specifically on climate, and more specifically dialysis. So this is an agenda of what I'm going to talk about today. We're going to Grand Round, so I'm going to start with the clinical case. Then I'm going to give you climate change 101 from a nephrology perspective. Disclaimer, I am not a climate scientist. And then we'll talk about the impact of climate change on kidney health and healthcare's contributions to climate change, as well as a project I have to try to increase resilience in patients with end-stage kidney disease in the event of climate disasters. And throughout the talk, you'll see images of climate change. A lot of them come from NASA's website that is amazing. This is one of a lake in Oregon, which was where I was born. And you can see that this was the lake in 2002, and then this is it just a few years ago in 2022. And in nephrology parlance, we would call this hyponatremia and this hypernatremia. I'm glad you guys laughed. My lawyer husband did not think it was funny. He was like, I think that's euvolemia, the first one. Anyway, so we'll start with the clinical case. So JB is a 54-year-old with type 2 diabetes who had been on dialysis for 3 months. He had begun getting used to the schedule of going to dialysis regularly and was working with his renal dietitian because he got started for hyperkalemia when all of a sudden his dialysis unit had to close down. And that's because it was 2005 and he lived in New Orleans. And this is an image of New Orleans before Hurricane Katrina and the city afterwards that resulted in a large number of dialysis units closing in Louisiana. He missed several treatments. He was hospitalized. He was evacuated to Houston, and he eventually moved to Aurora. And that's when I became his physician. And I had just become the medical director of the unit, and I walked in to meet Mr. JB, and he turned to me and said, "What is your plan if this dialysis unit has to shut down?" And I was a very young Dr. Young at that time, and it was really anxiety provoking to think about that challenge. So JB was not the only dialysis patient that was adversely affected from Hurricane Katrina. So end-stage kidney patients after Katrina had increased hospitalizations, especially if they evacuated late, if they were socially isolated like my patient had been. And we had a real challenge finding places to dialyze these patients across the country after Katrina, because we had a huge number of dialysis patients who were evacuees from Louisiana. And then the longer impact to this community was there was a significant decline in the number of transplants that occurred in Louisiana. We know that transplantation improves mortality in dialysis patients. And so a lot of patients were left dialysis dependent as a consequence of the storm. This is just a graph of the number of transplants they were doing and time in the Louisiana area, and you can see a dramatic decline. Well, subsequent studies have shown that in the wake of a hurricane, dialysis patients have a higher mortality. So this was a study that looked at counties that were affected by hurricanes between 1997 and 2017, and they used the USRDS database. It was mostly in-center hemodialysis, but they also had some home patients. And what they found was that mortality was increased after a storm. And so this is just a graph with the hazard ratio and the days after the storm. And that increased mortality was highest in the day after the storm, but persisted for 30 days afterwards. We also have a study out of Hurricane Sandy, which also showed a similar increased mortality. The thing about the Sandy study that was interesting, though, was if you preemptively dialyze someone in anticipation of a storm, you could reduce their mortality. Well, what about Helene and Milton? So we don't know. It's too early for us to know what the impact on the end-stage kidney disease patient is right now. But we do know that large numbers of dialysis units had to close in the states that were affected. I just pasted what was on the DaVita newsroom for North Carolina. And while they were able to open up their other units to try to accommodate the patients that were, their home unit was closed, all of you know that dialysis patients under the best of circumstances have trouble getting to their dialysis unit. And now they're dealing with infrastructure disruptions and they have to get to a different dialysis unit. So we'll just have to see what the consequence of that is. And then all of you know from the Epic, when you log into Epic, you get a little message that says, don't use IV fluids, which is really hard for a nephrologist, I just want to say. And that's because Baxter, which produces most of the PD fluid in the US, had a factory in North Carolina near Asheville, and it had to stop production for a period of time. And so as a consequence of that, there's a disruption in the supply chain of IV fluids, and we currently are not able to start new patients on PD because of that disruption. So my take-home points from the clinical case is that climate events have been happening for over 2 decades, and end-stage kidney disease patients are particularly vulnerable. And patients have been asking us to increase resilience in that community for as long as I've been practicing nephrology. Now, many in the audience are saying, okay, Sarah, but we don't have hurricanes in Colorado, so how long are you going to talk about hurricanes for? But climate change has other adverse consequences that do affect kidney health. So here in Colorado, we need to worry about fire and heat. So now I'm just going to turn and talk really briefly about climate change and what the factors are that are contributing to it. The purpose of this is not for you all to become climate scientists experts. I certainly am not. But in order to talk about how to mitigate, how to build resilience, we need to understand the factors contributing to the warming climate. So unfortunately, there is no homeostasis in climate. Climate change refers to the long shifts in temperature and weather patterns, but it's a very chaotic system. And the climate has radically changed over the history of the Earth. But those changes in the past have really been from periodic oscillations in the Earth's orbit that affected sunlight that led to those changes in the temperature on the surface of the planet. Since the 1800s, the main driver of climate change is human activity. So this is my PowerPoint depiction of all the factors contributing to the greenhouse effect. We've got the sun. This is the only polar bear you're going to get for this talk. It's a climate talk. I know you have to see a polar bear, but this is the only one. On a glacier, we have ocean, land, manufacturing that's resulting in the greenhouse gas emissions, of which carbon dioxide and methane are the most important. We convert all those greenhouse gas emissions and we talk about CO2 equivalents when we're talking about carbon footprint. Nothing on my PowerPoint is to scale, just to be clear. So one of the reason we have the greenhouse effect is that when sunlight reaches the Earth and it hits ocean or land, those dark surfaces absorb the energy. If it hits something that's white, that ray is emitted back into the universe and it's not absorbed. It's able to penetrate the greenhouse gas emissions and then it's emitted right back into the universe. However, the energy that's absorbed by ocean and land gets re-emitted at a different wavelength, and that gets trapped by greenhouse gases. So these are just graphs of how carbon dioxide and methane have changed over the past few decades. So this is carbon dioxide in parts per million and with time. And you can just see there's just been a steady increase since 1960. And all the carbon dioxide emissions are from human activity. Methane is a much more powerful greenhouse gas, but it lasts in the atmosphere considerably less, only about a decade, as opposed to carbon dioxide, which a good portion of it just is there forever. And you can see that methane too has just increased over the past few decades. And if you take a longer view and you look at the past millennia, you can see that at no point did carbon emissions increase above 300 parts per million until the Industrial Revolution in 1911, and it's skyrocketed since then. So if you have anybody in your family who doesn't believe in climate change, this is on NASA's website. I would recommend you download it, take them out for coffee, and show them that. Similarly, from NASA's website, you can see that the increasing in temperature on the surface, which is right here in red, is not a consequence of increased solar energy that's coming to the planet, okay? Because they measured that in solar irradiance in yellow. So despite a decrease or stabilization in the amount of sunlight we're getting, the temperature on the Earth is just increasing. And as a consequence of that, we're losing Arctic sea ice. That gets measured in September when it's at its lowest. And you can see in the past few decades, just a continued decline in Arctic sea ice. And that's a problem because when we lose Arctic sea ice, we have less albedo effect. And so there's less sunlight being sent back into the universe. That's why I'm wearing all white, to try to increase the albedo effect. If it were only that simple. And then as a consequence, there's also sea levels rising, and dark ocean absorbs sunlight. So it's warmer. Well, with a warming planet, it's not so much that for some diseases, it is the increase in temperature that occurs on a daily basis. But the bigger problem that we've seen most recently are the extreme weather events that occur as a consequence of that. And that leads to very significant public health and social infrastructure. There's also reduced crop yields, and that's leading to refugees, immigrants that are leaving places where they cannot survive anymore because of changes in the climate. And all of that leads to decreased human health. So we're in a little bit of a vicious cycle because these heat waves, these extreme weather events, food insecurity, and a change in infectious disease patterns that is also occurring as a consequence of the warming climate, all is leading to humans, people needing more healthcare. But healthcare itself is a producer of greenhouse gas emissions. So if you take the entire world, 5.2% of global emissions are from the healthcare industry. If you take the United States, of the US economy's carbon footprint, 10% of it is from the healthcare industry. If the healthcare industry were a country, it would rank 13th in the world in terms of greenhouse gas emissions. So now I'm going to talk about what is the impact of climate change on human health, and I'm going to focus really on kidney health. So this is a study that looked at mortality because of heat-related mortality that could be attributed to climate change, okay? So if you take the world as a whole, 37% of deaths from heat-related mortality can be attributed directly to climate change. However, what you'll notice, and what is most distressing to me personally, is the disparity that you see between countries. So this first circle represents 0%. And then the bar is a country. The next circle, you can barely see it on the PowerPoint, is 20, 40, and then up here is 60. And what you can see is countries like Ecuador or Colombia or Guatemala, where I spent my youth, are seeing extremely high rates of mortality related to climate change. And these are countries that are not responsible for carbon emissions. Well, there are a whole host of health outcomes from heat waves, acute kidney injury being the one I care the most about as a nephrologist, but there's also heat stroke, adverse pregnancy outcomes. There's more and more emerging research about the impacts on mental health, and then exacerbations of respiratory and cardiovascular disease, and I've already shown you data for mortality. So who's at risk? Well, the elderly and the very young are more at risk, and patients with chronic medical problems. Pregnant patients are also at more risk, and then indigenous people and outdoor workers or members of lower income households or socially marginalized groups. Well, my patients with CKD and end-stage kidney disease have a lot of these risk factors. So this is a particularly vulnerable patient population. And we have our first study back in 2019 looking at what is the consequence of heat waves to end-stage kidney disease. This was a study that was done in Philadelphia, Boston, and New York. And what they found was that in end-stage kidney disease patients, there was an increased same-day hospital admission and mortality rate during a heat wave. An earlier study in 2006 looked at excess hospitalizations during a heat wave they had, and what they found was that a lot of the reasons patients were getting admitted were renal reasons. So electrolyte imbalances, acute renal failure, nephritis and nephrotic syndrome. I find that very interesting. That's a persistent finding. And then, of course, heat-related illnesses. And then I can't talk about a warming planet and kidney disease without mentioning CKDU. So CKDU is a chronic kidney disease of uncertain etiology, and we don't know all the factors that contribute to CKDU. What we know is that there are epidemics around the world of this disease. It's occurring predominantly in agricultural workers who are in the hottest parts of their country and are doing outdoor labor and strenuous work. And the clinical characteristics of this disease they get low-grade non-nephrotic proteinuria, hyperuricemia, and hypokalemia. And while all the factors in any given country might be different, the unifying characteristic is that most of these people are agricultural workers working in a very hot environment. And so this is just pictures of some of the places that have been the hardest hit. It's referred to as Mesoamerican nephropathy in Central America, but Sri Lanka has also been hit. I think many of you may have seen there was a recent New York Times article about it. And then Udinam nephropathy in India. I Googled how to pronounce that. So if I pronounce that incorrectly, blame Google. There are whole categories of medications I do not pronounce correctly because of Google. So it could have been left. The other way in which the warming planet is resulting in poor kidney health is kidney stones. And so we have a multitude of studies looking at temperature metrics and heat waves and increased risk of kidney stone presentation in the subsequent 2 to 3 days. So since 2014 to most recently 2023, while the temperature metric or how they defined an extreme temperature event varied slightly, all of them showed an increased risk from as low as 8.2% to as high as 73%. And that men seem to be more severely affected. And that increased incidence of kidney stones occurs within 3 days of the heat event. And one of the theories for why this is happening is because of urban heat islands. So because cities don't have enough greenery at night, the temperature does not drop the way it should. And at night, our urine is the most concentrated. And so urban environments where the temperature is not dropping at night may be contributing to those kidney stones. And so that has led people to believe that what is called the kidney stone belt is going to move north and west with time. So the kidney stone belt refers to the southeast part of the United States, where the prevalence of kidney stones is 50% higher than the rest of the country. But because of the rising climate, we anticipate that to move north and west. And I still remember the first patient I ever saw passing a kidney stone in the emergency room on the south side of Chicago. And I will never get that image out of my brain because of the pain that little tiny thing could cause. So what should you do for your patients during a heat wave? Well, fortunately, one of your interns in our internal medicine residency program, Levine Kashna, wrote an article with us giving you recommendations about how to manage your CKD patients during a heat wave. And what we talk about is first making sure that your patient knows how they should be hydrating at baseline and how to adjust it in the event of a heat wave. We also need to educate patients not to be going outside during the middle of the day, to take cover, and how to protect themselves if they don't have AC where their cooling center is. We also want to educate them about the signs and symptoms of heat stroke. Patients should be evaluated for acute kidney injury in the way that you always evaluate for acute kidney injury, but with particular emphasis on volume status. Patients with CKD might want to be monitored by blood pressure and chemistries more regularly, and they want to review their medications and determine which of their medications might need to be adjusted in the event of a heat wave. We also really need to engage with public health professionals, to make sure that the communities that we care for are getting the message that a heat wave is coming, so that they can properly prepare and mitigate the heat that they experience. And lastly, we recommend that everyone have what's called a heat action plan. So Levine put together the graphic, because she's better at that than I am by far. And what we recommend, just like patients who have asthma have an asthma action plan, or epilepsy have a seizure action plan, we recommend a heat action plan. So that patients know where their nearest cooling center is and how to get there, that they know how they should adjust their hydration during a heat wave, and what medications they should stop. So for example, I tend to counsel my patients to stop their SGLT2 inhibitors. Some of them I might want to reduce their diuretic on, and then educate them about the signs of heat stroke. I'm now going to pivot to talk about other ways in which the changing climate is adversely affecting kidney health. This is a picture of New York 2 summers ago, when the Canadian wildfires led to a large amount of smoke to go down the eastern seaboard and settled right in New York City. I happened to be in New York City when this was happening, and you literally could not go outside. So everyone thinks that the complications of wildfire smoke are respiratory. Well, that's not just respiratory, okay? So unfortunately, air quality improvement in the United States is literally going up in smoke. So this is a study looking at air quality since the 2000s. And so this first panel, A, and the black represents the observed change in air quality. The way we measure air quality is annual average particulate matter of 2.5 microns or less. And you can see that since 2000, there's been a steady, nice decline in particulate matter, which stopped in 2015. And that stop in 2015, we can attribute to the rise in wildfire smoke. The counterfactual is the bright blue. And if we hadn't had the wildfires, we would have seen a continued improvement in air quality. The second panel represents what states were adversely affected by that. Some states, I think IDs, Idaho, Rhode Island, not so much, okay? But places like Oregon and Nevada, 100% of the improvement in air quality that they had this century has been completely reversed. And when we look at Colorado, we've undone about 50% of the improvement in air quality that we've seen. And we now have a study that shows that air quality is associated with CKD and end-stage kidney disease. So this was a study published in JASN that had over 2 million veterans, and they followed them for almost 9 years, and the increased particulate matter exposure was associated with CKD and end-stage kidney disease. And probably the most distressing part about this study is that the amount of particulate matter exposure that you needed to get was pretty low, okay? So I think there's more and more interest in particulate matter contributing to chronic kidney disease, and maybe even CKDU, because they burn the sugar canes in Guatemala, and so there might be a lot of particulate matter that patients are exposed to. And there's also some evidence that our patients with end-stage kidney disease have a higher short-term incident of cardiovascular events and mortality. And this was a study looking at the USRDS database, where they showed that patients on dialysis were more likely to have a cardiovascular event or die if they had particulate matter exposure. So I've reviewed for you a bunch of ways in which the changing climate is leading to kidney disease. We've talked about heat waves and acute kidney injury, rising temperature leading to kidney stones and maybe being a contributing factor for CKDU, increased air pollution leading to chronic kidney disease. And because I'm very good at following instructions, and they told me my talk could only be 45 minutes, I have skipped over all the infectious disease reasons that cause acute kidney injury, but the warming climate is making malaria and dengue much more able to replicate much more effectively. And so we're seeing a distribution of those infectious diseases throughout the world, and those 2 diseases in particular are associated with acute kidney injury. Before I move on to talk about the contribution specifically of healthcare to the changing climate, I just want to take a moment to talk about climate change and mental health. The case that I presented at the beginning of this, JB, he clearly was suffering from PTSD from his experience at Katrina. And there was a study that showed that a year after Katrina, end-stage kidney disease patients, 1/4 of them had PTSD as a consequence of the event. The CKD and end-stage kidney disease patients already have higher mental illness than the general population. So about 26% of patients with CKD have mental illness, and 9% of them have serious mental illness. And we have growing evidence that during heat waves, there's increased suicides. And we know from Maria especially that the rates of PTSD after a hurricane are extremely high. There's also a new entity, and that's called eco-anxiety. That's what all of you are experiencing right now in the room as you hear me speak, because thinking about climate change is anxiety provoking. And when the Yale Center for Climate Change actually surveys Americans, the rates of concern and worry about climate change is very high. So this is a map from their website. I would encourage all of you to look at it. I find it fascinating. You can really narrow in on particular places. But there's a big disparity in the amount of eco-anxiety depending on where you live. So as a country, about 65% of Americans are worried about climate change. In DC, 80% of the population is concerned about climate change. Weirdly, West Virginia and North Dakota are not so concerned. So now I'm going to turn and talk about the impact of climate change of the healthcare industry on climate. So this was a study looking at healthcare's contribution, and the first panel, it's just busy, so I'm just going to take you through it, is showing what percentage of a nation's total carbon footprint is from the healthcare sector, okay? And so these are all the different countries that they looked at, and the United States is right here. And you can see that in this study, it was 8%. Of our carbon footprint is from the healthcare sector. The darker bar within it represents how much of those emissions are actually occurring within the boundaries of the country. And the reason that's important is because if you want to regulate healthcare's carbon footprint, it's going to be hard to regulate manufacturing or events that are happening outside of the country. But a big portion of our personal carbon footprint is occurring within the boundaries of the United States. Just as a point of comparison, poor little Luxembourg, most of their carbon footprint is occurring outside of the country. So if they decided to try to reduce their healthcare carbon footprint, it's going to be a lot harder. The second panel is healthcare carbon footprint per capita. So how many carbon emissions are occurring per person in the country? And the United States is way, way above anybody else. And then I've just put here, obviously, the bigger your economy, the bigger your healthcare carbon footprint and the bigger your carbon footprint in general. So China actually puts out the most CO2 in their healthcare, but we're right next to them. And then it drops off pretty dramatically. And interestingly, Latvia has the lowest. So I'm going to make an assumption here, but I suspect that dialysis is a big contributor to the healthcare carbon footprint in the United States. And that assumption is based on the fact that we dialyze people more than anybody else. And about 1% of the Medicare population is on dialysis, but 10% of the resources for Medicare go to dialysis patients. And where money goes, that tends to be where carbon emissions go. So this is a graph with the rising number of patients on dialysis from 2010 through projected to 2030, and you can see that it's only on the rise. And then if you look at where it's on the rise the most, Asia and the United States are the two places where it's rising the most. So what do we know about the environmental effect of dialysis? Well, we don't know a lot because it really hasn't been measured. And most of the studies that have been done outside of the United States. And people outside of the United States don't dialyze as much or exactly the same way. So it's sometimes not comparable, but I'm going to tell you what we do know. And I'm going to talk about the water usage in dialysis, power usage, waste generation, and I'm going to show you the one study we have of a carbon footprint in the United States. So hemodialysis is extremely, extremely water hungry. And that's because in order to create the dialysates that we use with patients, we have to use a reverse osmosis machine. And a reverse osmosis machine is the most expensive piece of equipment in a dialysis facility, but it wastes a ton of water. So some of the most inefficient ones will waste 50% of the water that goes through the machine right down the drain. So for a 4-hour treatment, there's a minimum of about 240 liters of water being used. As a point of comparison, most US households or most US citizens use about 310 liters in a day. So one dialysis treatment is approaching the amount that one person needs in a day. In reality, the amount of water used is much, much greater than that. So 240 is the minimum. Even if you could reduce the water waste to zero, you're still looking at about 120 liters for a 4-hour treatment. So that was the bad news. This is the good news. With pretty simple measures, we seem to be able to reduce the amount of water being consumed. So this was a study done in France, in the Fresenius company that's called Nefrocare there in France. And all they did was take their dialysis facilities and update their RO system, okay? And so this yellow line is a representation of how many treatments they were doing. And you can see, and the red line is a representation of the amount of water used per treatment. So as soon as they increased their, they updated their RO, they were able to dramatically reduce the amount of water they were using from 600 liters per treatment to 300 liters with that very simple measure. Very simple, but extremely expensive. Well, what about power usage? Well, hemodialysis appears to be very power hungry as well. If we take a Fresenius machine and an RO and a reverse osmosis machine, those portable things you see the nurses like hauling up to the ICU if you need to dialyze someone in the ICU, that takes about 6 kilowatt hours to dialyze someone for 4 hours. That's comparable to running your AC for 2 hours. The next stage machine, which we use for CRRT in the ICU and which we use for home dialysis, appears to be considerably less power hungry with about 25% of the amount of power. The other way in which dialysis is really adversely affecting the environment is specifically through waste generation. So there's a tremendous amount of waste created. Hazardous waste, which leads to emissions. We've talked about the problems with that. Tremendous amount of landfill that leads to phthalates, and a lot of that landfill is plastic that leads to phthalates in our groundwater, methane, and less than a third of the waste created in a dialysis facility is recyclable. And the only study we have looking at the amount of waste that's being generated is from the United Kingdom, but they measured the waste to be 2.5 kilograms of solid waste each session, and 38% of that was plastic. And when they compared, they looked at their total waste for the United Kingdom healthcare industry, 30% of all their waste could be attributed to dialysis. So this is the only study that we have looking at the carbon footprint of a US dialysis facility. But this looked at 15 hemodialysis facilities in Ohio, and it looked at their carbon emissions. And they estimated that the annual emissions per facility were about 369,000, and per treatment about 59,000. But the most important part of this study is that there's a threefold variation in emissions across facilities, which means that there were some facilities that were emitting many fewer carbons molecules than others. And so if we could identify the best practices in the dialysis facilities that are emitting less carbon and standardize it across dialysis facilities, we could substantially reduce our emissions. Well, what about peritoneal dialysis? Well, we only have 2 studies really looking at the carbon footprint of peritoneal dialysis, and unfortunately, neither of them were done in the US. It's very hard to compare carbon emissions outside of the US to carbon emissions inside the US for a whole variety of reasons. But we think that the environmental impact of peritoneal dialysis is considerably less. Most patients only require 6 to 12 liters of fluid in a day, but they're doing it every night as opposed to 3 times a week. And what we don't know is how much water it takes to create the plastic packaging that the PD fluid is stored in. However, the waste generation is considerably higher, almost double what hemodialysis is. The one study we have looking at the carbon footprint is from Australia. And this is just manufacturing and disposal of the PD fluids. And they found that the carbon footprint for APD, which is automated peritoneal dialysis, that's the dialysis that they're doing here in the hospital, where a patient gets hooked up to a cycler and the fluid gets pushed in and pulled out while they sleep, was about 1,900. And when they looked at CAPD, which is not using the cycler, where the patient manually puts fluid in and drains themselves, it was considerably lower at 1,245. And I'm just going to show you the data for that. So this is that study out of Australia. And the blue bar is, APD, and the green bar is CAPD, and these are the kilograms of carbon emissions. And then it just breaks down what component of their dialysis was contributing to this. The important part of this study is that this was not taking into account transporting the fluids. So if you have to transport the fluids somewhere, it dramatically increases the carbon footprint. So if you were in the Northern Territory and you were on APD, it pretty much almost doubled your carbon footprint. And in the United States, and Dr. Teitelbaum can probably attest to this, a lot of the patients doing PD are not in urban centers. And so the fluid needs to get to them wherever they are. And so it's going to dramatically increase the carbon footprint. Well, what about transplants? We don't know what the environmental impact of transplant is. We have one poster that was actually put together by Monica Groffels, who used to be in our transplant center here. It was her master's thesis when she was at Harvard School for Public Health, where they computer modeled peritoneal dialysis, hemo, and transplants. And they say that transplant reduced the environmental impact by 96% when it compared it to hemo, and 90% when compared to PD. So again, we're in this vicious cycle where kidney disease is leading to hospitalizations and carbon emissions that are leading to climate change and climate events. And those climate events are adversely affecting our patients being able to get dialysis during the climate event, but it's also leading to more kidney disease. So what are we getting for our carbon footprint? It's not so great. So this is a graph looking at healthy life expectancy and then the carbon footprint of different countries. And this is where we are. We're emitting more carbon and we're not living as healthy as we should. So I'm just going to end by talking about a project that I'm starting up to try to increase climate resilience in the end-stage kidney disease population. So I'm finally getting back to that question my patient asked me 20 years ago. So I have a collaboration with the CU Boulder engineer, Sherry Cook. She's an environmental engineer, and I think she's like the nephrologist of environmental engineers because she does solid waste management and water treatment and management of pharmaceutical waste. And we have two other people on the project. We have Eli Yoder, who's an engineering student, and Amy Lee. And what we're going to do with the help of Sherry is we want to compare in-center hemodialysis, peritoneal dialysis, and next stage home dialysis. We want to look at their carbon footprints, and what Sherry does is basically deconstruct the machines and the process and determines the carbon footprint. And then we want to stress all of those dialysis modalities in a computer model and put them through hurricanes, flooding, drought, and see which perform the best under those environments, okay? It may be that if you're in Florida, it might be better to be on PD if there's a hurricane. We don't know. It might be that certain areas are gonna be, dialysis patients are gonna be more resilient to certain climate events. And I think that we can also, once we know where the problem is, with Sherry's help, we can start to modify current technologies to increase resilience. The other thing about this project that's interesting is that once we get it going and have figured it out, it's something that could be applied to other procedures. It could be applied to a cath lab, a GI lab, and do a similar project. So I'm going to end by just talking about climate change and the role for the healthcare community. Obviously, what JB told me 20 years ago is that climate change is coming for all of us, but it's not coming for all of us equally. And there are certain populations that are particularly vulnerable, and we need to do research to identify those populations, and we need to do research to try to improve, adaptability and ability to sustain those climate events. We also need to measure our own carbon footprint so that we know how to mitigate and how to reduce it. And with that, I'm going to end with what I think is a very positive story. This is a quote from Dr. Jane Goodall. She says, "What you do makes a difference, and you have to decide what kind of difference you want to make." So I'm going to give you an example of what my son, who is 21, is doing. So my son dumpster dives. And I know I'm proud of my dumpster diving son. But this is a picture of all the wasted food outside of a grocery store in Boulder. Wasted food is a huge cause of methane emissions. So what he and his colleagues do, I'm not giving you his name because I think it's technically not legal, is that they salvage all this food. And this is a picture of his Boulder apartment with all the food that they've salvaged. And they then cook it and they feed the unhoused. So I feel like this is a beautiful example of reducing emissions while also taking care of the community that's most affected by climate change, the unhoused. So if my 21-year-old son is our future, it's going to be optimistic, okay? Because he's figured out how to do it. But I also think we need to use this small example as a way, how can we do that here? How can we reduce our emissions while simultaneously taking care of the most vulnerable populations? And with that, I'll take any questions.
Dr. Young, thank you for an enlightening Grand Rounds, a sobering tale, but also I think for raising an incredible human being. That's a great story to end on.
He came out that way. I have no responsibility for that.
Maybe I'll lead us off with questions. And I guess my first question is, it's expensive to be climate resilient. From what I heard you say in terms of healthcare systems and facilities, those machines cost more, the cost costs more. Are there incentives or policies in place encouraging us to be more thoughtful in this? And if not, why not? And what can we do as a healthcare community to perhaps advocate for that?
Yeah. Well, first of all, I'm not sure we know how expensive it is because there are studies like out of Australia that have shown that if you put solar panels on and you make these interventions, you actually in the long term can save money. So I think that's an excuse for not making the changes, but I don't know that it's definitely true. I know that most corporations, it's very popular now to have a climate policy, but that needs to translate into action. And those companies, in fact, I think every large dialysis organization has a climate plan, statement. That's right. But we need to start holding those companies accountable. Ultimately, this needs to be regulated. I think dialysis is a great place to start that, honestly, because CMS is also already very involved in regulating outcomes in a dialysis facility, and they could just add another evaluation of all these facilities, which is how, what their carbon emissions are and how much water they're wasting.
Yeah. Questions for Dr. Young in the audience? Dr. Ernest.
Thank you. Thanks for a great talk. I have read or seen somewhere that there are like hospital systems can sign on. There's sort of a environmental pledge that they do. And I have to say, just walking around this institution, if you go through an empty clinic at 6 o'clock, all the lights are on, all the screensavers are burning. It seems to me there's some pretty low-hanging fruit that we could do, but it really, nobody seems to be paying attention to it. So sort of two questions. One, I think, are there, culturally things we can do and should be doing to attend to this ourselves? And then secondly, is there a conversation to be had with the institutions we're part of about ways we might look at this and metrics we might measure to make progress in this?
Yeah, 100%. I think there's some serious low-hanging fruit. I know that I work on the weekends a lot and when I walk into RC2, I'm constantly turning off all the lights because the lights are on. Dr. Chanchel has received an email from me, I think, in the past about the lights on the weekend in RC2. The challenge with a big organization like this is that it's so huge, and so it's not real agile. I hope no one is offended by that statement. It can be difficult to be agile in a big institution like this. So I'm obviously not in a position to in any way affect the institution at large, but we as individuals can 100% turn off those lights as we're walking down a hallway. Make sure our computers are off or, at least on screensaver. And I would empower all of you, and I think that's sort of the point of telling the story about my son, is that there's some really small ways that we can behave that can have really large impacts on our climate, on the climate. What I tell my fellows is that when they're putting a line in, you don't want to burn anything that doesn't need to be burned. So nothing should be going into that, the red box if it doesn't have to. It should go somewhere else. And so those are just really simple ways that we can change. I hope that answers your question.
Additional questions? Yep.
Chairman? Hello. Great talk, Sarah.
Thank you,
I'm
Jen.
curious about the particulates you were talking about. How do you think that actually increases the risk of kidney disease specifically?
Yeah, I think that's not known, but I think that they're small enough that it's thought that there's systemic exposure, that it gets past the alveoli and there's systemic exposure. Rick, do you have any other thoughts about that?
I'm sorry. Thank you. Yeah, some particles can actually get through into the blood and into the kidney, and one of them is silica. And silica is released from sugarcane burning, and we've found it now in a number of kidneys of patients who are developing chronic kidney disease associated with heat stress, where we think it's contributing to the injury. In fact, we're doing a study right now in Aguas Calientes, Mexico, where these small silica particles are also in the drinking water. And we're finding it in a very significant number of people with developing kidney disease. So we think these small particles, and they don't have to be silica, they can be other things, but some of them are capable of getting to the kidney where they are taken up by macrophages that can't get rid of them. And because they're like plastic or this or that or silica. And so it causes a thing called frustrated phagocytosis and low-grade inflammation. And then that can cause kidney damage. It probably goes to other organs too, like the liver. We're finding it in the liver, in the spleen, and in the lungs.
Also will say great talk. I wonder how we as a healthcare community can better advocate to our policymakers about how this is impacting our patients and how we can, make policies that may protect them or help them, their overall mortality and morbidity from these climate change effects.
Yeah, I would encourage you to read our article on heat waves in CKD, because Levine actually has a whole part on advocacy. Personally, I think that our patients know that they're being adversely affected by the climate. And so because to make policy change, it requires people to be engaged in voting, I think it's helpful to have a discussion with patients, and the context for, could be a heat action plan about how climate is adversely affecting them. And that then motivates them to insist that their local and federal leaders take climate change seriously. I can't think of a person really that hasn't in some way been affected by climate. I mean, all of us in this room have been affected by the most recent hurricanes. So I feel like in some ways that's the most effective way is for me as a clinician.
Any more questions for Dr. Young? The online? Okay, well, Dr. Young, thanks so much.
Thank
for a
you
lovely
so
talk.
much.